It's a pleasure to introduce our speaker, Wendy Burchell, and she has worked for the Health District for 20 years. And in this time, she's worked in both assessment and in healthy communities programs. Wendy's also the county's child death review coordinator, and currently her title is Healthy Community Specialist, Injury Prevention with a focus on youth suicide prevention and infant safe sleep education. She's also a certified QPR, which means question, persuade, refer, suicide prevention gatekeeper, training facilitator. So welcome and thank you, Wendy, for presenting today. We're glad everyone's here. I'm sorry again about these problems we're having.
No, that's fine. Thank you for having me. I see something that looks familiar.
Good.
So I guess I'll just let Emily know when I want the slide changed. And until we get the video going, I'll just expand a little bit. Thank you for the introduction, Sue.
Sure.
So through my work with Child Death Review, recommendations are made for prevention of future deaths by focusing on modifiable risk factors and population level trends, real public health work. Modifiable risk factors are those that can be changed, unlike genetic or fixed environmental conditions. The recommendations are targeted to specific systems like healthcare, public health, schools, law enforcement, etc., or policy bodies, including those who participate in child death review and other entities that can reduce the risk factors to protect children. Child death review allows me to collect real-time data on child preventable deaths, including suicide. The focus on youth suicide prevention is important because if mental health and childhood trauma are addressed early, it may give the young adults tools needed to prevent adult suicide. And so what I want you all to take away today are some tools for your toolbox to prevent youth suicide. A couple things. I also have some lived experience. I've raising 3 boys. 2 of them are seniors in high school. And they've pretty much gone to high school during the pandemic. So that's been very eye-opening. And then I have a 22-year-old son, and 2 of the 3 of them have some mental health challenges. One of them does work with his own issues around suicidal ideation. And so we've been down that road. So my professional life and my home life have kind of met each other in the middle. Carrie says I can turn my video on now. Let's try that. Also, I'm just getting over a double ear infection, and the medication they gave me makes my throat dry out. So I apologize if I take extra sips of water, or I'm gonna pop half a cough drop in my mouth so that I'm not stuttering halfway through the, okay, you see me now? Okay, good, you see both? Okay, great. Okay, well, let's move on to the next slide then. And I'm gonna be sharing, a lot of information. So I'm gonna try to go slow. I don't know if someone's monitoring the chat or the raise hand box, but if they could just relay questions, or if we want to wait till questions at the end.
We'll do our best with that. We'll do our best with that, and then we can do at the end too.
Okay, sounds great. Okay. So I'm a data person, so I always like to start everything with data because it gives us a really good picture of what we're dealing with in our community. This is suicide rates of youth aged 10 to 17 over time. So from 2014 to 2020, in comparison with Washington State. So the orange line there is Washington, and we're the dark gray line. Even though our line looks rather jumpy, it appears different than the state level rates, but there really is no statistical difference between those rates. throughout those years until we get to 2020, where we had 0 youth suicides in Snohomish County, and I'll address that in future slides. However, just because it's not statistically significant does not mean that the data isn't meaningful. Clearly, something was happening in 2018, where we did have a rather large increase in youth suicides in our county. And if I remember correctly, we had some small clusters in, I think, Stanwood and Marysville around that time. And we display youth suicide rates as rates and not as numbers because the numbers are small. So while suicide is impactful, our numbers are small. And if the numbers are less than 10, we have to display as rates because then they're potentially identifiable. So that's a little mini statistical lesson there. Next slide. So this is just a snapshot of suicide in our community for 1 year, 2020. It shows that Snohomish County falls right in line with national statistics, with white men ages 45 to 64 dying by suicide the most. And you'll notice again, in 2020, we had 0 in our county for youth, and that is not the norm. And we will talk about that a little bit coming up here. So next slide. So basically, well, one thing, I'm excited. We have healthy youth survey data from 2021 now. It just came in March, and our epidemiologists have been working really hard on getting that analyzed and out to us so we can share it with everyone. And I said, please do the mental health pieces first, because I want to share those first. But this is basically a warning, a caution, because of course, in the prevention world, we like to look at changes over time. And for Healthy Youth Survey, we really need to proceed with caution if we're going to compare with previous years, because the survey was technically supposed to be done in 2020, but because of COVID, it was put off and done in 2021. So a whole different cohort of students were surveyed, and students were not living in comparable conditions in that year compared to years previous. So as we look at Healthy Youth Survey data now and in the future, just keep that in mind as a caveat. We don't want to say it's not comparable, but that's definitely something we have to keep in mind. So next slide. So the survey asks 6th, 8th, and 10th and 12th graders a myriad of questions about their health and their home and their school life. But many of the mental health questions are not asked of 6th graders, only 8th, 10th, and 12th graders. So I'm not leaving that out. The questions just weren't asked. So you can see here, again, not a significant change since 2012 of youth who seriously considered attempting suicide. So not seeing a change is something good, positive. However, we still need to keep in mind that there are 20% of our youth, pretty much across all of those grades, who are considering suicide. Next slide. So the dark bars here represent the pie graphs that I showed on the previous slide. But then the other questions surrounding suicidal feelings were, have you made a plan about how you would attempt suicide, and have you actually attempted suicide? And the only element here over the years that's statistically different than the prior survey is in 2018, where the 12th graders making a plan about how they would attempt suicide is actually lower. Or I'm sorry, in 2021, it's actually lower than in 2018. So in 2018, that figure was 19.5%, and in 2021, it's 13.8%. So that's a positive change. Again, but we still have 20% of our youth who are planning to die by suicide. Next slide. This is a little more positive and hopeful. This is the Children's Hope Scale. So they ask students, how hopeful are you for the future? And then you can see the scale across the bottom there. And most students score as highly hopeful or moderately hopeful. And we know that having hope for the future is a protective factor. Youth who struggle with suicidal thoughts state that they often just feel hopeless. And this is why offering hope in any form is a best practice for preventing youth suicide. So next slide. I see a question pop up. So there is a group of people every year or who meet at the state level to determine what questions are asked in Healthy Youth Survey. The question was, why aren't sixth graders asked the suicide questions? I don't sit on that committee, but I'd like to, because I do believe those questions should be asked. Because I know in recent years, we have had middle schoolers die by suicide, which is new. That's not something that happened even 10 years ago. So I don't think it's too early to ask those questions. And I think maybe the group could use a little education around suicide, because my thinking is maybe it's that myth that if you bring up the topic of suicide, it'll put the idea in youth heads. And that's simply not true. So that is something that I would like to work on in the future so that sixth graders are asked those questions. But that's a good question. So with all that information, we had 2020 where there were 0 youth suicides in the county. And like Sue said, I've worked at the health district in this role. I've been child death review lead for the 20 years that I've been here, and we have not seen 1 year with 0 youth suicides. Now, I know you're probably all familiar with what was being said in the media. We kept hearing youth are dying by suicide at, higher rates. Mental health is extremely problematic, which I think it's always been problematic, but the pandemic sort of shone a light on our youth's mental health struggles. But then our county saw 0 in 2020. So Child Death Review said, you know what, we need to look at this and look at why this happened in our county. So we gathered. And again, given that the pandemic began during this time, we wanted to discuss, well, what were possible protective factors that may have been in place during this time that might have prevented youth suicide? We also wanted to discuss that youth might be at higher risk as we moved into another year of the pandemic. So that would have been moving into 2021. And we had potential for higher numbers of youth who were experiencing mental health crisis or conditions. So I will give you some information that we discussed about all of that. Next slide.
We have a couple questions, Wendy.
Okay.
Do you want me to read them to you?
Sure.
Okay, so, well, Amy asked about the 6th grade, not asked the previous questions. And then Jessica said, hope that happens. Jessica Kirkwood. And then Jennifer Hudson says, we notice more students disclose LGBTQ positive, curious if county data just disaggregated in relation to subgroups. That's one of the questions. Yeah.
That's interesting. Yeah, that's a good observation. I know at the Children's Wellness Coalition at our May meeting, we're going to break down some of the Healthy Youth Survey data by race, ethnicity, LGBTQ, those type things. So we'll take a deeper dive into that data at that time, and that might provide some more insight on that as well.
Mm-hmm.
So.
And then Julie Harris says, I think the move to telemedicine has been crucial to access to therapy.
That's a very good point. Yes, that's a very good point.
Mm-hmm.
Yeah, and we don't have that in our notes, so that is a good point. Well, we also, when we entered into the discussion, we thought, well, okay, it's great there were 0 youth suicides, but maybe ER visits and 911 calls tripled during this time. You know, we kind of wanted to look at that also. So I gathered 911 dispatch data for suicide, suicidal ideation, overdoses related to suicide attempts, or any intentional self-harm for ages 10 to 17 from 2017 to 2020 October, because that's actually when I put in the data request. So as you can see, though, there was not a significant change in those 911 dispatch calls during that time frame either. These are not ER visits, these are just 911 dispatch. So whenever EMS, police was dispatched via 911 for that criteria, these are the numbers of calls around that. So again, we thought, but we did note we do need to monitor ER data, and that's much more difficult to get. But that's one of the goals, which we'll bring up here in a minute. Next slide. So no sudden increase in 911 calls. So again, we were asking ourselves what could have been happening during this time. And this is what we as a group discussed and came up with. So these are the protective factors. And we talk about protective factors for suicide, youth suicide. Keep in mind that these can all be individual or group interventions or areas of focus for prevention. It's kind of a nice way to categorize, oh, I don't know what to do in regards to suicide prevention. Well, these are all really good starting points. Kids were getting more sleep. There's data out there telling us that kids who get more sleep have better overall outcomes in everything. So this was not surprising. More family time, more family interaction. And we all noted we wanted to put more time with pets because, again, spending time with pets and having a pet is actually a protective factor for youth mental health and youth suicide, because it gives someone something else that depends on them and cares for them. So it's a protective factor. Less juggling of commitments. They're not as overextended. You know, many events were canceled or postponed. Less in-person bullying. My boys commented on the next one, more flexibility in terms of their schedule. They could take ownership of when and where their schoolwork was completed. I know for both of my guys in high school, this was huge for them. One of them had started working during this time. So again, it offered him more flexibility on when he could do his work. You know, they weren't sitting at a desk from 7 a.m. to 2 p.m. So they both expressed this one personally as well. And we noted this as a group. Maybe less academic pressure. Testing was withheld for this time period. Less classroom distractions and chatter in the classroom, especially for those who maybe have an anxiety disorder or ADHD or ADD. And then more supervision. And this is bolded because we talked about this a lot and we're still talking about this because people are still like, why, you know, why? We really want to know the why so that we can move forward with effective prevention in this area. So we talked about supervision. So data tells us, and we know that youth who die by suicide usually do it when they're alone, unsupervised, or they actually leave the home. So during COVID restrictions and having more families at home, there was less opportunity for the youth to be alone. And this was regardless of whether or not the home was a safe space. Simply having an adult around or others in the home may have been an actual deterrent to a suicide attempt. So basically, there were more eyes on the child more often. And that could have been enough to keep kids from dying by suicide. So next slide. So we talked about some other risk factors that are in addition to the traditional risk factors, which I'll go over a little bit here too. Unpredictability. I think we were all kind of living, and some of us still are living in a time of unpredictability. During a pandemic, you know, the days, weeks, and months, we weren't really sure what was going to happen next, what was going to come next. Lack of coping strategies. So this is developmental among youth. So they have things that they're trying to cope with. They don't, you know, their frontal lobes aren't developed. And then you pile on all the extra things that the COVID restrictions and COVID brought with it. And it's just a lot to cope with. And there's a lack of coping strategies. We talked about the kids who became disengaged from school. Some of our school reps said once school went remote, we lost track of kids completely. Like we didn't talk to them, or we couldn't find them or engage with them at all during lockdown. So that was a big concern about those kids. When home is not a safe space, if the kids are home more, but that space is not safe, that could create trauma and may lead to other mental health issues or possible suicide attempts. And then of course, being home more means that they have an increased access to firearms. And again, when we look at the risk factors, just like when we look at protective factors, these are all areas where we can intervene with suicide prevention activities. So next slide. So these were just a few of the recommendations that came out of our discussion. The resources to schools after a suicide is something that we talk about all the time. It's not really unique to this discussion. We need to make sure that schools have the appropriate tools for responding to a suicide. A crisis response plan is ideal, but not every school has that. There's also a toolkit from AFSP that can be downloaded. It's free, it's amazing, it's very thorough. But everybody has to have it, know about it, and know how to use it, and use it every single time in a crisis, whether it's a suicide, the loss of a teacher, you know, the loss of a student due to an illness, across the board, the same crisis response plan. Suicide risk assessment screening for all open CPS cases. So we learned that they do suicide assessment screenings for cases where suicide risk has been noted in the home, but only through caseworker observation, not necessarily a screening. So it was recommended that they do an actual formal screening for all open CPS cases. Adapt the school crisis plan, if they have one, to virtual learning. This might not be as relevant now, but it's always good to have, just in case. And then here again, we really need to start monitoring ER data for mental health crises so that we have a better picture of what's happening with our youth. Okay, next slide. Are there any more questions before we jump into?
Yeah. Andrea, can't read her last name altogether, but says NAMI, New Hampshire, has a Connect post-vention training that can assist schools in planning for post-suicide death response.
Okay, that's great, because we're always
Yeah.
looking for models.
And then Julie Harris says, what are the barriers to getting emergency department data?
Well, one of the barriers is we have to have a data sharing agreement, so that just on our end has to go through administration. I don't know if it has to go through the Board of Health, and then it has to go through the administration on their end. But that's just one piece of it. We're currently getting data from the hospitals for our opioid overdoses. And that's been challenging because it's not consistent. I think whoever's supplying the data has other work and we don't receive it consistently or timely. And I know that's been an issue for ER data as well. So those are just a couple of the the barriers we're having to getting it. So someone said I'm going too fast. I'm sorry. So we're going to jump into the suicide clues and warning signs, and these are actually the risk factors. So the more clues and signs observed, the greater the risk, and take them all seriously. I did pull these next few slides out of my QPR training because I think these things are really important to know because they're kind of like the baseline of suicide prevention. We need to know what we're looking for if we want to prevent a bad outcome. So we have, right, these are the suicide risk factors. There might be one repetitive clue, or there might be several different clues or risk factors present all at once. So just keep those things in mind.
We have a question from Jennifer Larkin Keller. Have you discussed or considered getting a collective medical account? This is the platform most hospitals and clinics use to get notifications of admissions and discharges to follow patient populations, and you can assign settings for certain diagnoses.
Oh, no, I'm not familiar with that, but I will definitely look into that. And it seems like something the health district should have anyway, considering all the other, you know, diseases and illnesses we work with. So that's a good lead. Thank you. So next slide. So I won't read, I mean, these are pretty obvious. These are direct clues, direct warning signs. But when you look at these, think about, most of these are not communicated verbally, because how do youth communicate these days? How a lot of us do, actually, I guess. It's not just unique to youth. A lot of them text, they use social media platforms, things we as parents might not even see. So just again, as we go through all of these risk factors and clues and warning signs, keep that in mind. These aren't all verbal, in fact, probably very little. The only one I want to touch on is that last one. If such and such doesn't happen, I'll kill myself. I work closely with Volunteers of America. They run our crisis line here. And they said every spring they get a little uptick in calls because a lot of the high school students are getting their college acceptance letters or rejection letters. So they hear that a lot. If I don't get accepted into such and such college, I'm going to kill myself. So that is enough of a stressor to some youth to where they feel like they're in a crisis. So next slide. So some more indirect things. I'm tired of my life. I can't go on. Who cares if I'm dead? I just want out. I won't be around. Pretty soon you won't have to worry about me. There's kind of a common theme among all these and variations of these, and that's of burdensome. Another one of the myths around suicide is that it's a selfish act. It is not a selfish act. In fact, folks, and I use this term a lot, people who are in that dark place, that place where a lot of us can't even imagine being, they feel like they're actually doing their loved ones a favor because they don't want to be a burden to them. I've heard kids many times tell me, you know, my parents are just so stressed. They have job issues going on. We have money issues happening, and you know, or we're taking care of my sick grandmother, and I don't want to burden my family with my own problems. So that is quite common. The feeling of being a burden to others. Next slide. So behavioral clues. Any previous suicide attempt, which many of us are probably not going to be privy to. We probably won't have that information. But we might, especially if we're a family member. Keep an extra eye on those. Acquiring a gun or stockpiling pills. Now, I like to point out here, a lot of these things, if these are out of the ordinary, so if you know that your friend Steve is not a hunter, he's not a firearm collector, and then all of a sudden he appears on Snapchat with a firearm, making statements like we saw before, or just something that's out of the ordinary. If it's something that makes you go, this is not really typical behavior for this young person, that's a warning sign or a clue. So it's not just that somebody acquires a gun maybe as a birthday gift, but if this is just out of the ordinary for this person. Putting personal affairs in order, they give away prized possessions, things that are important to them. They know they won't need in the future, so they give them away. Sudden interest or disinterest in religion. Co-occurring depression, moodiness, and hopelessness. Drug and alcohol use, especially after a period of recovery. Unexplained anger, aggression, and irritability, especially in young adolescent boys. Depression can often exhibit as anger, aggression, and irritability. So it's kind of the opposite of what you'd think. They could maybe have that moodiness or that sense of hopelessness, but they also have these bursts or outbursts of anger or irritability that, again, seem out of the ordinary. That's something to pay attention to. Also, we know that youth who've died by suicide, and I see this frequently, we see substance use used as a coping strategy. So if you know youth who are using substances, don't just jump to the conclusion or assume that it's a teen experimenting or following a trend. Ask them why. Because it actually might be that they're masking some kind of pain or feelings that they're having a hard time coping with or dealing with. So in order to do that, they're using substances. And of course, right now we see a lot of that with a lot of marijuana use with our youth. So next slide. So some situational clues: being fired from a job or expelled or suspended from school. This is again where a lot of times school is the only place where youth have structure, safety, and home is not their safe place. So if we expel or suspend a student where that is the case, we are sending them back into an environment that is more trauma-inducing. So something to keep aware of. A recent unwanted move, a loss of any relationship, of course, the death of a loved one, especially if by suicide. You're at higher risk, youth, anyone of any age, if you have a loved one who's died by suicide. Sudden unexpected loss of freedom or fear of punishment. Again, with youth, this is a little different. It's not, I stole some candy from the corner store and I might go to Denny. It's more, I might get my phone taken away, or I might be grounded to my room for a week, because that's cutting them off from their social supports. And that's something that is a legitimate fear of youth. And another one, when we talk about loss of major relationships, breakups for teenagers are huge. They're just very significant for youth. Again, they have the lack of coping skills, and then they've got all these big emotions that are happening for the developmental stage that they're in. And they've probably just lost a relationship that was one of their first. It was maybe their first love, again, with lots of big emotions attached. So youth breakups are very significant. And, we as adults and we as parents, we know that they will go on to, meet other people, but youth, they're not thinking that way at the time of a breakup. So definitely something to keep in mind. Next slide. So how to help somebody who's in a crisis. And this is very condensed, kind of high level. But really it's, and when I do my QPR classes, it really is simplistic and simple. And we're talking about when they're in a crisis. So not necessarily someone who is in a continual state of needing mental health therapy or treatment, but when someone is in a mental health crisis, listening and being present is very powerful. So listen to the problem and give them your full attention, and don't rush to judgment. Again, listening is really powerful.
I have a couple of comments here.
Yeah.
Let's see. Whoops. Oh, shoot. Rhonda Monroe says clues can also include really dark art images, as well as using black or red ink. And then Jennifer says, for exclusions from school as a consequence. You said home could be the danger. With the data, maybe home isn't more trauma inducing. Although I absolutely realize we get in trouble when we are ... in trouble, and that is, and that is more stressful.
Yeah, I think I know what she's asking or stating. It kind of goes against, because we thought the same thing as the child death review group. We thought, well, why would being at home more be a protective factor when home is not the safe space for these kids? And in regard to that specifically, I think it's, well, what we came to is because it's simply having eyes on the child, not necessarily because that place is safe, but because, and again, it doesn't mean that that child is not experiencing trauma or being abused or whatever is making that home unsafe. It just means they're not attempting or dying by suicide because there's eyes there. Does that make sense? So that is sort of that hard dichotomy with, yeah, having kids at home when it's not safe versus, well, we're saying it can ward off a suicide attempt possibly. So
thanks, Wendy.
Yeah. So I bolded offer hope in any form because that is another one of the main points of my QPR trainings. Again, it sounds so simple, but when we think about how often do we really engage with people who might be in a crisis or just feeling depressed or having an episode, uplifting them by offering them hope is very, very powerful. And it's simply by telling them, you know, you matter. And I like to use things that talk about or bring their mind into the future. So, you know, I really want to see you next week. I want to see you tomorrow. I want to see what your art project is going to look like that you're going to turn in on Friday. Like, it's those, so it gets them thinking about the future, but also gives them a sense of hope. I was thinking we could do a whole like breakout session on like ways to offer hope. One example I know at my kids' school when they were freshmen, they did a sticky note campaign where one of the clubs went around and just put sticky notes on every single locker with all these hopeful messages. You're important, you matter, and they all came up with them themselves. And it looked amazing, and it sort of uplifted the whole space. So it's little things like that are really, really go a long way. And the other thing is get others involved. If you're having a conversation with a young person and you know they're really close with their sister, you know, say, hey, can we let your sister know what's going on so she can also be someone in your corner and offer support, you know, while you're struggling. or, anyone else that may be close to that person who could use extra support. And also you as a support person, so you don't feel like you're helping this person alone. And then this kind of goes along with the offer hope in any form, but follow up with them. If you've had a conversation with a young person who's been struggling and it seems to have resolved for the most part, still follow up with them with a text or a note or, any way that you feel appropriate, so that you really did mean what you say when you met with them, that you care about them and their future. Again, and there's evidence to back this one up as well, that following up with some kind of written message offers really good outcomes for the youth. So next slide. Okay, this slide's a lot of words. I know, I'm sorry. I won't read them all to you. You can all read. Oops, sorry, something just popped up on my own screen. Get rid of that, okay. The point is, we know a lot more about suicide now than we did even 10 or 15 years ago. And I think these are a few of the really important takeaways. And the first one I think is really important. Suicide is complex. It is another myth that suicide is caused by just one incident or one event, and understanding that it's complex helps us to address prevention efforts. Mental health and or substance abuse have been found in 90% of people who have died by suicide. And again, to someone who's in that dark place, suicide is their only solution to stop that emotional pain. They have thought about other ways, but suicide is the last resort that they have thought of to end their emotional pain, and sometimes their physical pain as well. And like I mentioned earlier, depression, anxiety, and suicidal crises are actually livable and survivable by most who get help. The majority of people who struggle with these things on a daily basis do get help, and they do survive, and they do not die by suicide. So it's those hopeful messages that can also be prevention messages. And this kind of falls right along with that. People who survive suicide attempts, we learn a lot from suicide attempt survivors. They tell us they didn't really want to die. That was the only way, again, that they could come up with to end their pain. And then the last one is another good prevention strategy: safe firearm storage. Actually saves lives. Remember, the goal of prevention is to modify risk factors and to focus on harm reduction. So simply locking up firearms appropriately could potentially save kids' lives. And in our county, that would probably be about half of them. Next slide. Oh yeah, I saw that comment come up, the SAS or the student SSA, also the student support advocates. We were just talking about that here among my colleagues this morning, how much schools have changed over the last even 10 years. And school support advocates are such an amazing resource. And I know a lot of the middle schools have them now as well. It started out just in the high schools, but middle schools have them. I don't know if grade schools have them, but again, a wonderful resource to have for our kids. So how we as the community can help, because some people are like, well, I don't know what to do. These are just, again, some high level things we can do as a community to work on keeping our kids alive. Take trainings, offer trainings like mental health first aid. That's an 8-hour course. They do have a youth focused one. I've taken the youth one. It's really, really well done. It's thorough. It goes through not just suicide prevention, but it talks about anxiety, depression, all those mental health things that affect youth. QPR is question, persuade, refer, and it's a gatekeeper training. And then there's Talk Saves Lives, which is done through AFSP, the American Foundation for Suicide Prevention. And it is very similar to QPR. It's another suicide prevention gatekeeper training. And I'll talk a little bit about that later because there's a group in the community that's working on that right now. Partner with your area mental health providers. Just keep that conversation about suicide in the forefront. We need to talk about it. First of all, to reduce stigma. It's okay to talk about it. And we should be talking about it. Utilize all your social media platforms to relay survivor stories and stories of hope. And again, you don't have to recreate those. The AFSP website has a lot of those you can look at, use, regurgitate, repost. These aren't things we have to create individually ourselves. They exist. We just need to share them. Be the source for timely and accurate data about suicide in your community. Again, this one's near and dear to my heart. Again, especially during the pandemic when we were hearing a lot of noise around the globe about youth mental health. And I'm like, that's just not really what's happening here. And I think it's just so important to have an accurate picture of what's happening in our own community. Then provide crisis line information and resources to pretty much everyone you work with. However you see appropriate. A lot of the student IDs now have resources on the back of them. I think that's a wonderful idea. So stuff like that we can all do in our communities and in our workplaces. Next slide. So again, why do we talk about it? I said we have to talk about this all the time. So discussing it in person, in the media, however, with one-on-one with our own kids, with our kids as friends, if we talk about it appropriately, it helps to change public misperceptions, correct those myths that I still hear all the time. It helps reduce stigma, which is a huge barrier to help seeking. So we really need to talk about it to reduce that stigma. And then encourage the vulnerable to seek help. So help seeking. And all of this will help to prevent future suicides. Next slide.
Wendy?
Yeah.
Where have you left off on the comments? I had a distraction that I had to tend to.
I don't actually, I just see them, on my screen, they just pop up and then they disappear.
Okay.
So
Okay.
I don't.
Let's see, we have a question by Jessica Kirkwood. Will there be a class on how to help youth through these trials? And then Laura said, great idea, Jessica.
Okay.
So that's one or a couple comments. Do you want me to keep going or do you want to answer that first?
Well, so the next couple slides, I'm going to talk about the Talk Saves Lives through AFSP and how the Youth Suicide Prevention Task Force is trying to push that out to the community. I'm not trying, we are doing that. And you can always contact me and I can connect you with folks who would love to come and train or talk to whatever groups of youth that you serve or work with. So use me as a resource, please.
And then, okay.
Oh, go ahead.
Great. Julie Harris says, yes, I would love to be able to do first aid. And Andrea says, based upon medical examiner data, how often are substances, alcohol, other substances present in deaths by suicide for teenagers in Snohomish County? I think you answered that.
Yeah, I don't have an exact number. I mean, I could get that from our database, but I want to say at least 80%. It's very common, and it's not. We just note substance use. We don't differentiate between substance abuse or misuse or use. It's a lot of times we'll just hear it from like the police report or the ME report that someone who's died by suicide used marijuana frequently. You know, it's stuff like that. So we don't differentiate between the quantitative piece, but
Mhm.
it is extremely common. Yeah.
Okay. And then Joe Stevens says that be presenting at the NAMI, ending the silence on May 4th from 9 to 10 a.m. through the Providence Health Fair Faith and Wellness Group via
Well, that's
Teams.
wonderful.
Yeah. It will deal with youth mental health, illness and suicide prevention, and says you can contact me, and gives a website if you're
Okay,
interested.
that's great. Yeah, NAMI is another amazing resource. Yeah.
Okay. Jennifer says makes sense. Good point. Jessica had put thumbs up. Does it need to be near future?
Oh, I think that was in regard to the hope to the future, right? It doesn't need to be
Okay.
near future, but
Okay.
get them thinking about the future or focusing on the future. Yeah.
Okay.
Whether it's
So-
short-term or long-term. Yeah.
Okay. Joe,
So-
sorry, go ahead.
No, go ahead.
Okay, Joe says, if time permits, 2 to 3 minutes, I would like to talk about a pilot suicide prevention program we're getting established in 2 area high schools where we hope to grow it.
Yeah,
And
I'd be
then,
interested to hear about that.
Jennifer Shaw says SAPs can help as well. Almost every school has a student assistance professional. I'm sorry. We specialize in drug, alcohol, mental health. I work through the ESD, and I'm stationed at the district and worked with students in crisis all the time. However, most families are not aware of us. And then says most communities also have prevention coalitions that have training and funds for training. We just
Right.
formed a new one in Sultan, which are working with stats from the Healthy Youth Survey.
Yay.
Yeah.
Okay.
Alyssa says, do you have any, I'm sorry, do you want to talk? Or just
No,
have
go
me keep
ahead.
going?
I'm actually
Okay.
writing stuff down while you're
Okay.
talking.
Alyssa says, do you have any recommendations for any free mental health first aid training?
Okay, yeah, I did see that one pop up, and you can visit their website. I have them on my list of resources at the end of the presentation, and I'm assuming the presentation is shared with everyone when we're done.
Yeah, actually, Micah says, will you be providing a copy of this recording to the attendees? Isn't that available through our website
Yeah, I'm not.
or our Facebook page?
Sure.
I think our Facebook page, Homebush Health District Facebook page.
I do believe it gets posted somewhere, yes.
Yeah. And then Jennifer Shaw, will we be able to access minutes from this training, as there seems to be lots of resources and training opportunities? I'm not sure about that. I think there might be a way we can send out these slides to Wendy. Is that
I
acceptable?
mean, I can get them to you. I don't know how you would send them to everyone who signed up via that website, but I'm sure there's a way. Yeah.
Okay.
So, but yes, the slides will be available. We'll figure out how to get them out there. If not, I'm sure we could put them on the website. So, because there are some links in here. So,
Okay, great.
so I just wanted to point out that one of the really great things that's happened in the last year, we just had our 1-year anniversary that's happened to address youth suicide. I don't know if you're familiar with the Children's Wellness Coalition via Snohomish County Human Services. We have started a subgroup of the Children's Wellness Coalition. It's the Youth Suicide Prevention Task Force. And these are all the things that we're plan on working on in the future. And like I said, we've been meeting for a year. We've already done a few things. It's a fantastic group. And again, even if activities don't happen all the time, it's an amazing networking and learning community. So I'm just excited because I've only been doing the suicide piece of this work for about 7 or 8 years now, and I feel like I've been kind of a lone soldier, even though I know I'm not, but I never really had the chance or opportunity to connect with other people in the community doing similar work. So now we're all sitting at the same table. So I'm really excited about that. So we are coordinating with the Department of Health and Forefront and AFSP. So that's one of the goals, is just to coordinate with other entities who are also doing this work. We want to, again, coordinate community work so we can provide very specific and targeted interventions. And we want to identify gaps so that we can leverage resources, no duplication of services, that type thing, and implement best practices across the community. Next slide. It's just continued. Some more things. So one of the other goals is to provide technical assistance and training. And that's one of the things we have really jumped into in the last 3 months, is we're really pushing out Talk Saves Lives training to communities. I'm on the subgroup of communication, so I've just been sort of creating the flyers and links and that type of thing to sign up. I know they've done them in Lake Stevens, Snohomish, Monroe, and this is through some of the community coalitions. Others have just been advertising it through their workplaces. So we would love to push that out to more folks. And it seems like a lot of you on this training are interested in something like that. So definitely reach out to me and I can get you connected with how to either attend one of those, or if you want to host one, we can work that out and make that happen. We also want to identify policy gaps, because we know a lot of public health and change doesn't happen without the backing of policy. So that's something else we're going to be working on. And here is the link to the Wellness Coalition at the bottom there, and the task force. If you are interested in becoming a member, there's an online application there after you read through what we're all about. So yeah, I knew there'd be people interested in those trainings. They're great. I'm actually going to switch from being a QPR trainer to being a Talk Saves Lives trainer, just for continuity and consistency across the community. So next slide. Now, when I talk about resources, there's a lot of resources in the community, but I have to say we are so lucky to have the Care Crisis Line here. It's housed here. It serves a Tri-County area. And I think it's very underutilized. And I think a lot of that has to do with, I think the perception is that you have to be the person in crisis to call. And that's not the case. And we've talked a lot about this in the Youth Suicide Prevention Task Forces. They are a wealth of knowledge, staffed 24/7 by professionally trained staff, not volunteers. So I like to use the example of the schools are like, we don't know when to call the crisis line. Well, that's probably exactly when you should be calling the crisis line. That's exactly what they're there for. If you're sitting in your office with a student and you're just, I don't know what to do, I don't know what next steps are, call them. They will help you through that process. Of course, if you or yourself are in crisis or a loved one is in crisis, reach out to them. But if you just have questions about the mental health system, you know, a friend of a friend has questions, but they don't know who to ask, give them a call. They're an amazing resource. Yes, so Thurston County would probably be plugged into Snohomish County. And that brings me to my next piece of this is, I don't know if you've heard that 988, the national crisis line, will be pushed out in July. We just had a meeting about this because nothing on the back end is going to change. If folks dial 988, they're going to get this service that's right here. It's just how they access it that's going to be different. And that's happening because obviously if someone is in crisis, they're not going to remember a 1-800 number or the local number, which are go to the same place. And I even tell people if they contact the National Lifeline, that's fabulous. That's a wonderful resource, but you're going to be put on hold and they're going to transfer you to this number. So just skip that step and go right to here. But 988 is going to bypass all of that. It will be much easier for the end user to access this resource. So we're excited about that. They are hiring like 20 more professional staff to help answer phones because they know that it's going to be more calls coming in. And then the imhurting.org is also part of them. And this one's great for youth because a lot of youth don't want to call someone. They don't want to call a crisis line. They'd rather get on their device and they can just go in and chat. So it's like a chat room with somebody confidentially. So use this at any opportunity you feel the need. So next slide. So here's some of those other resources. I could have made pages and pages, but these are most of the ones I've mentioned here in this presentation. So that's why they're listed here. So there's the mental health first aid link. It's really easy. If you just go to their website and then you type in your location, it'll give you where all the classes are happening in your area. Some of them are free. Some of them have a small fee because it comes with quite a large book. And some of that cost is not covered in some areas. And then you can also reach out to them and say, well, I want to host a training. Like we talked about that here at the health district. And there's some parameters around that, but they can do that. So yeah, texting the crisis line and the hope line, youth like that much better than calling. Yeah, that's just not cool for youth, or they're not comfortable doing that. The Trevor Project is a wonderful resource for LGBTQ folks. There's also, it's not on here, it's rather new, it's the Trans Lifeline. Again, another amazing resource for our trans community. And all of these are wonderful resources. And again, there's more, and that's another task of the task force is to compile an updated resource list for us all. So next slide, and I believe that's about all I have. How are we doing on time?
Sue left, so I am keeping an eye on things, Wendy.
Okay.
And let me check my clock. It is 4:07 now. I think we're scheduled until 4:30.
Okay.
Here, you got 2 more to look at.
All right. If anyone has any questions, or again, I can't really see the chat. It pops up and disappears.
Think you answered Jennifer Larkin's question about them being available in Thurston County.
Yeah, good job. It's gonna be so good.
I saw that one, job seeker.
Look, she's got a new one for you. Right there.
Oh, it just escaped me. The resource center that's down at the Everett Transit Center.
So fast?
What is the name of them?
Sister.
Is that
2 more, that's it.
Job Corps? One of my kids had to take
It
it.
is
Yes, WorkSource. That's it.
They don't
Thank
have
you.
their own job, right?
They might be a good resource for that.
Yeah, no, that's it for now.
Yeah, we'll be.
And I don't know if
We used to
so right now there is no cost for Talk Saves Lives. It is free. That's why we're trying to push it out. It's also shorter. So mental health first aid is great. It's a wonderful training, but it's 8 hours, and we know that's really hard for a lot of people to block an 8-hour day out. And Talk Saves Lives is 90 minutes. And we've been trying to offer it in the evenings so that it doesn't interfere with people's work days.
Doodle.
Snickerdoodle factory.
No, this is the snickerdoodle factory.
Someone's talking about noodles.
All right.
Oh, forgive me, my children and their grandmother are cooking in my background.
Okay.
This is all about my reading.
Okay. Are there?
I'm level 15 at the end of the school year, but now
Sorry, Laura, I'm not going to mute as I'm helping. I'm helping the host.
Yeah, it's about reading.
Do we have an email for you for more information, Wendy?
Yes, it's right. It should be the one that's up on the screen there.
Yep,
W.
right.
Burchell at snowhd.org.
There's that. I need you to be quiet, please. Thank you.
Yep.
Can I see your here?
Yeah, you can email me and I can, because I'm not sure where the next ones are happening, the next Talk Saves Lives trainings. But I can definitely get that information for you.
Did I miss a spot? There you go.
See, I'm just trying to find where Sue left off. Wendy.
Well, like I said, I can see they like pop up, and if I read it real fast, and then they disappear.
Did you talk about SAP, how SAP can help as well?
What is SAP?
Not sure. Jennifer Shaw said SAPs can help as well. Almost every school has a student assistance professional.
Yeah, that's a student support advocate or student. Yeah. Yes, we did talk about that.
Does it need to be on there? I think that's, we got everything. Not sure.
Oh, I see. Actually, I just opened the Q&A.
Oh.
Let's see. So the ER data associated with substance use and OD attempts could include mental health component. Yes, that's definitely something that I would ask for if I'm going to go down that road of looking for ER data, because we actually, my team, we just received a grant on addressing the intersection of ACEs, overdose, and suicide.
Ladies.
So
Sophia.
I think that ER data is going to be really important for that grant work that we're going to start working on in the next year. So thank you for that, anonymous attendee. Can you supply a list of agencies and apps that can be accessed? I can do that. Again, I can, that's one of the tasks of the task force, is to provide an updated resource list. And apps, that's another good suggestion, because there are quite a few apps out there now that are, again, and youth especially like to use apps. So that's a good suggestion. I'm going to write that one down, but I will try to get all that. Apps and resources.
Claire Walderman asked if you could clarify suicide myths again, because she was driving when you discussed it earlier.
So one of the myths that I addressed in here is we see it in the media a lot. You'll see student dies by suicide after being bullied. That's probably common. People have seen that. Well, the bullying was probably most definitely a trigger to that youth dying by suicide, but we know that suicide is complex and there is always more than one component to why people die by suicide, not just youth. It's much more complicated than just one instance or one thing that happened at one point in time. Those folks were probably already at higher risk for suicide. For, again, maybe they have a lot of trauma in their life. Many things could be happening, but the myth is that one thing causes suicide, and that is simply not true. Another one that I mentioned is that suicide is a selfish act. We hear that a lot. And a lot of times if you're talking to youth especially, and you say, you know, that's so selfish, you know, you're only thinking of yourself. Again, we know talking to youth who struggle with suicide ideation, and youth or people, not just youth, who have survived suicide attempts are like, no, my thought process is that I am a burden and I don't want to be a burden to my family. So in their thought process, it is not selfishly motivated by any means. And I think once we understand those things, it's easier to look at prevention efforts if we know, you know, where we're coming from on that. So I saw another question just pop up.
We have, I think, a couple comments and a question. Jennifer Larkin said, I think she may have said a couple of things. When you update these resource lists, the apps, websites, numbers, etc., how will they get that information? And she said, I apologize if you've already answered this.
Well, again, this is the first time I've worked with this group. So my thinking is when I have that and when it's all compiled, I can share it with the leads of this group and they can somehow get it out. The other thing is I know that Youth Suicide Prevention Task Force and the Children's Wellness Coalition, that website link I had on there, we should be posting all of that on there in the future. It won't happen tomorrow. Like I said, we're working on it right now, but those things will be posted there.
Jennifer also asked that you had mentioned taking a teenager's cell phone could increase the risk for suicide for feeling isolated. What do you suggest if parents have legitimate reasons for removing these devices, such as tablets and phones, etc.?
Yeah, this is a tough one. This comes up a lot. And again, I have 3 boys who are hooked to their electronics a lot. Clearly it falls down to, you know, parental discretion. However, so from my personal experience, if I know that maybe some of the things that are triggering to my kids are coming via those electronic platforms, yes, it would be appropriate to take those away. However, I don't want to also cut my child off from the only connection they have to their other social supports. Again, in a time of crisis, I'm talking about it in a time of crisis, not just, you know, every day take cell phone away. But if my child's really struggling, really having a hard time with it, and I know that they rely on those other social supports that they get via that device, I would not take it away personally, because that's what they need to stay alive. Now, balancing it with if there's something on those devices that is triggering, then yes, I have to take that into consideration. But yeah, that is a tough one. So again, I would maybe assess the level of risk that youth is facing at that time, the decision to take the device away. If you feel the risk of self-harm is lower, then yeah, by all means, if that's appropriate, then take the device away. But if the risk is higher, you know, let them keep a device. And then I noticed Joe wants to talk about his high school prevention program.
He does. I am leaving that open to you as you are our presenter. So I want there to be time
Okay.
for you to present.
Yeah, well, how are we doing on time? We've got about 10 minutes.
Yeah, about 10 minutes or so.
Okay, Joe, can you talk about that in 7 minutes? If you're still with us? Maybe Joe left.
Can you hear me?
Oh, yep, I can hear you.
Okay, I wasn't sure how to unmute. Okay, I just wanted to talk quickly. I'm on the Seattle Archdiocese Mental Health Board. And one of the areas that we wanted to center on for some focus was the youth, the high school students, things like that. Over the last 2 years, especially with them being isolated, there's much more mental illness that we're recognizing, and the suicide rates we go along with that. You know, they kind of go hand in hand a little bit. And so what we did is we started Living Works is the people we're working with. It's a national agency. They do training for suicide prevention. They have 2 types of training: Safe Talk, which is recognizing it, and there's assist training, which is preventing it. And what we did was we sent notices out to all the Catholic high schools, and the ones that were interested, we set up a training session, 2 2-day training sessions, and we had 8 high school students, 4 from 2 different high schools, that were very interested in it. And the training was just outstanding. What we want to do is these 4 students in each high school will go back to their high school, and they're going to give the Safe Talk training to their peers. And we think it's a wonderful model because no one understands each other better than your peers. And we as adults talk to the kids as much as we want, but the peers know how to talk to them. They know what language to use. They know all those things. And so we're setting this up in Archbishop Murphy and in and then Pope John Paul II down in Lacey. And if these go well, which we anticipate they will, we're going to try to roll them out in more high schools, more Catholic high schools, since we want to stay within our domain. But I've talked with NAMI about this, and they're very interested in maybe doing something for the public high school systems in that training process. And Living Works has never given the training to anyone under the age, I think it's 21. So they took a chance on this, saying, yeah, let's give it a go and see if it works. So this is a national test program, and it went very well, and it's taking off. And I have an actual case study that shows it from start to finish, how we developed it. If anybody's interested, I can send that off to them. But it's something I wanted to let people know about, because I think this is really the way to make an impact. And if a student has the ability to talk to another student that they know is safe, if they're having ideations of suicide, I think that can go a long way in keeping them from actually doing the act. And it's just the kids that got the training were just amazing. And I took the training as an adult, so that if the child, not a child, you're talking high school students, but if they have someone come to them and they feel they're in over their head, they can call me and I take it from there and get them to a safe place. And that's kind of how it works. And all the counselors for those schools were trained, and they had a couple of teachers in each school that got trained too. So they have people on site they can go to too if they have concerns that they feel they can't handle it. The idea is just to have the student themselves recognize it. Once they recognize this person is having suicide ideations, they've admitted that, then they hand it off to somebody who takes it from there. But it's a pilot program, and I'm so pleased with how well it's going. And we're hoping that in the coming years, we can make a big dent in the suicide numbers going down quite a bit.
Yeah, that's great. I am familiar with Safe Talk and Assist both. I just didn't know they had a peer-to-peer part of that. So that's definitely something I'm interested in looking into.
Yeah, this is totally new. This is groundbreaking. So it's we got permission. They got permission from the national to do it, and it's we hope we do a really good job so we can start branching out even more.
Okay, great. Thank you for sharing.
Okay.
Anything else?
Joe, are you able to share your email address? Sean T. Johnson would like to reach out to you.
Yes, I put it in the chat, but I'll say it now so you have it. It's Stevens, Stevens, F as in Frank, M as in Mary, L as in Larry, Y as in you, at msn.com. And my background is I've been facilitating a NAMI support group for about 13 years. So I've been involved with NAMI for about 13 years. So I'm pretty close to what we're talking about.
You love it?
Okay. Great. Everybody's had really great questions and feedback. I appreciate it.
Okay.
Can we slow down or help you do that?
So,
So Wendy, I went ahead and noted everybody's email that's shared.
Oh,
and
thank
I'll be able
you.
to share that with the trauma and resilience team,
Okay.
and you if you would like. Jennifer wrote a long comment. She said, I've also heard mention a few times of homes are not safe space for youth struggling with mental illness, despite results of showing otherwise through recent statistics. You mentioned this was potentially due to observation or supervision versus these spaces being safe. You know the stat. We know the stats. How often suicide occurs in troubled home versus homes and families considered to be healthy. Anyone who has raised or spent a few minutes around a teen is familiar with the moodiness.
All right, almost done. Here. Okay, I'm just gonna do this.
And at times withdrawn behavior around adults, especially parents.
Sophie,
Yeah, well, I don't know the stats right offhand. Again, we do through child death review, we do gather that information. But that is another thing I like to inform families when I'm out doing trainings, and I'm especially talking about youth, because I think there is a perception that suicide only happens to families that are not healthy or to kids who dress all in black or who are emo. There's this sort of image they have of suicidal youth. And I have to say, it's simply not true. I have seen youth who die by suicide from all home type settings, involved families, uninvolved families, high CPS involvement, no CPS involvement, very high functioning straight A students, athletes. It's been across the board. So to specifically look at maybe families who maybe have CPS involvement or something like that, we'd have to have some sort of criteria that we could search on. But I'd have to say it's kind of a mixed bag across the board. There is not just one particular look to a family or a youth who are, you know, working with youth who have mental health struggles. Because a lot of times, like if I go into a high school that is maybe in a wealthier neighborhood, and I get little to no attendance by families because I think the perception is, well, it doesn't happen here. You know, that this is not my kid or this is not our kids. And that, again, it's simply not true. So I don't know if that answers your question, but we could look at that data for sure over time, but it is truly a mixed bag. Anything else? I think it must be about 4:30.
It is 4:28. Does anybody else have any more quick questions for Wendy? I think under Q&A, we still have about the same.
Okay.
Everybody said thank you. That it was an excellent presentation.
Well, thank you for having me. I'm glad my voice didn't give out. I was really worried about that.
Yeah, so like I said, I noted everybody's email, so I'll make sure to share that. Yeah. So,
Thanks so much, Wendy.
Oh, you're welcome. Okay. Again, there's my email if you have any questions.
Where's your book?
Great.
all right, we will give everybody back 1 minute of their time because we know how valuable things are. And if anybody has any questions, you can reach out to Wendy at wburchell@snowhd.org or any of the Trauma and Resilience team.